Okay, so it's just gone 7:30, so I think we'll start this evening's session. So, big welcome to everybody who's joined us this evening. We've got guests from right across the sector, so thank you for joining us. Just one note that the session will be recorded, and you can access a copy of this recording at a later date. Or if you've got colleagues who've been unable to join us, then you will be able to get a copy. Details will be provided throughout the rest of the session on how to access that. So let's just start with a couple of introductions. So first of all, myself, Pete Horrocks here, one of the superintendents at Knights Pharmacy. I'm based up in the northeast, as you can probably tell from my accent. And joining us this evening as well is my colleague Mo, one of our other group superintendents who's based in the Midlands. So the purpose for tonight is to hopefully help you all understand the pharmacy quality scheme with a little bit more detail, but also to offer our support because we're all in this together. Certainly, we can hopefully present a shared learning, and sometimes it can be rather isolated, particularly in the independent sector. So just kind of reaching out to you for anybody who does need any support, that we can hopefully share that with you. So some of you may well have been aware that I recently gave a talk at the pharmacy show. And one of the things that was about was how we can make a success of the pharmacy contract. Now, it's no surprise to any of us that the pharmacy contract isn't new. It was brought to us in 2019 with a five-year plan. We're now rapidly into year 3, and the significant aspect of that contract was how our funding is going to change. So the 2.59 billion, what we saw is about 10% of that funding stream change due to the removal of MUR income and also the removal of the establishment payment. So about 10% of our remuneration was changing. But what we also saw as part of the 5-year view was a continuation of what was the pharmacy quality scheme, which is a significant part of income for all contractors. Also, we've got here some quotes from Simon Dukes, particularly around the recent negotiations. Many of you may well feel aggrieved that there was no changes in the increase in the contract sum for this year, and also not to have anything reflecting anything other than warm words is frustrating and supremely disappointing. But we've got what we've got. We can't really change that right now, so we've got to make the best of the situation that we've got, and utilise and maximise all opportunities our contract presents us. So that kind of brings us into the quality scheme for this evening, being a significant aspect of the contract at £75 million for all contractors. So points are going to be allocated varied upon the script volume. Most pharmacies will fall into band 4, where there's a maximum of 100 points available. Now, PCN lead pharmacies will be able to achieve an additional 10 points, but each point can work out to be between £67 and £135. Now, the reason for that difference is dependent upon how many contractors decide to participate in the scheme. But very simply looking at that, and up to an average contractor, the PQS scheme could be worth £7,000, or possibly more. So it's something that we shouldn't ignore, we shouldn't miss out on, and hopefully we're going to go through some of the key points of that this year. One thing that has been mentioned is that hopefully this PQS is slightly easier to achieve than some of the other ones. Recognition there from Department of Health that we're still, many of us, going through some of the pressures that COVID is facing us. Not to also forget some of the challenges we've got with staffing as well. But what you mustn't underestimate is there's still a lot of work to do, even with those warm words and an intent to make a slightly dumbed down scheme this year. Now, the payments will be made on the 1st of April, but critically, there's an aspiration payment deadline of the 29th of October. Now, that obviously For those of you looking at your watches now as to try and remember what day of the month we are, we're on the 25th already. So do make this an absolute key activity this week, even though it may well be half term and you've got some problem staffing shortages this week. Get your aspiration payment deadline in. If nothing else, it may well help with cash flow, as 70% of PQS funding is available once that is declared. Declaration process for that is very simple. Log on to your MYS login and answer the simple questions which asks which domains that you'll be completing. So I'm going to hand over to my colleague Mo, who's going to take you through the rest of the slides of this evening. We will have the chat function available, and we'll take questions particularly at the end, or if anybody has a burning question, then I'll be keeping an eye on these as Mo goes through the presentation. So thank you. Over to Mo.
Hi everyone. So as Pete stated, we will be addressing any questions and answers at the end. But like I say, if there's any burning issues, then I'm sure Pete, feel free to stop me at any point, and I'm happy to address them. The 29th of October, just a few days away, is your deadline for the aspiration payment claim. The 31st of December is the deadline to register an interest in uptake of flu, which is part of your PCN domain. So it's very important that contractors are able to get in touch with their PCN lead prior to that date. The 5th of January is the deadline for achieving your 20 NMS. The 31st of January is the deadline to achieve your target of 30 flu. And of course, it's also when the declaration portal opens, and the declaration portal then closes on the 25th of February. And we know that in the world of pharmacy, there isn't a huge amount of time, and days and nights just go by so quickly. So it's vitally important that we're well ahead. And what we want to do is we want to do something different, because a lot of the information is available to you via the PSNC, but we want to actually help and support you throughout that process. So we'll go into how we will hopefully make PQS easy for you by helping and supporting you throughout that process over the next few months with any burning questions that you may have. So let's go through the gateway criteria quickly. A lot of this would have already been addressed if you watched the PSNC webinar. You would have had a lot of information through. What we want to do is we want to also give you some advice and support initially in this webinar, but also across the way through to help you in your journey with PQS. Like Pete stated, PQS is here to stay for the next few years. It's really, really important that whatever work we do right now is future-proofed. So any future PQSs in the next few years become a lot more easier for us. So let's look at the gateway criteria in terms of NMS. So we know that the expectation is to ensure that pharmacies are actively promoting NMS to provide more clinical support to their patients. And the expectation is that 20 NMS are completed by the 5th of January. Catch-up NMS was introduced this year to provide support to patients who are prescribed a new medicine during the COVID pandemic. And this was obviously, this runs from April 2020 to the 31st of August 2021. The benefit is that there are new groups which are included in this, as well as in the catch-up NMS, and verbal consent is fine. It's also now possible for a pharmacist to provide NMS via telephone or video consultation, and it doesn't even need to be in the pharmacy premises. So what kind of stuff do you need to do to future-proof your NMS service? Because we're still seeing through farm data, a lot of pharmacies aren't doing the NMS service, which is seriously disappointing. Of course, not all PMRs are updated, and speaking with ProScript recently, there are still a few issues around the updating and the highlighting of at the new NMS groups. And this is obviously a problem for pharmacy staff that are reliant on the PMR to be able to give them that information. So what we've done is we've created some one-pages to help and support your pharmacy staff, and we're happy to share that with you guys around educating pharmacy staff on the importance, the groups, but also the brands, understanding which brands fit into the groups. And obviously, products have multiple uses, but it's important that your pharmacy staff highlight it for your pharmacist then to make a clinical decision. There's lots of support we can give you and help you with in that respect. The next part of the gateway criteria is ensuring that you have a safety report and demonstrable learnings from CPPE, LASA e-learning. So pharmacy professionals will need to complete this e-learning and assessment. If you've already done it, it's great. You also need to future-proof your pharmacy. What I mean by that is ensuring that your trainee pharmacists and your trainee technicians are also trained up as a matter of good practice, because they will need to do it at some stage anyway. And please don't leave it to the last minute, because you will get locked out. How can you take that further? So obviously you're going to have to develop a patient safety report, which will be different to the one that was done not in the last PQS, but the PQS before that. This can be an annual one, or it can span over a longer period of time. And of course, the learnings from the LASA e-learning need to be on that. One of the things that came up in this new part of the criteria was the need to ensure that we are passing this over to the learning from patient safety events portal. Of course, this is the replacement of the NRLS system. Now, eventually everything will move over to there already. A lot of us are reporting through our own internal portals, which is great, because if they're connected with the NRLS, fantastic. Especially with corporate portals, if they're connected with NRLS, it's not a problem. But of course, if you're not connected, you don't want to be reporting in 2 or 3 different places. So we've made a decision to actually just report directly through the learning from patient safety events. And if you haven't used it, it's fantastic. You can actually go back and look at previous incidents. You can also be able to send that across to your superintendent, etc. So it's a very easy to use system. And the documenting of incidents is really simple. So my advice is, try and integrate or try and move onto that portal as quickly as possible. When you report a LASA error, you do need to put LASA as a unique identifier, and that's how it will get picked up. Any questions on this, please put it on the chat box or the Q&A, and we'll address it at the end. Of course, there are lots of things that we can do to prevent risk, and I perhaps don't need to go through this, but just to kind of think about ideas that you want to put on your patient safety report. Individual error logs are brilliant, where you're monitoring trends over a period of time. So not just near miss logs, but is there something you can do to help and support a particular individual through setting smart objectives? And that's something that I'll seriously encourage and as part of their training. Obviously, we've got the things that you can do around physical separation, visual warning labels, etc. What kind of things can you do to reduce fatigue and tiredness? So there are lots of things that you can do. But one of the bits of advice I would give would be around setting smart objectives, individual members of your team that might potentially be at risk of making more errors. So going into the next part of the gateway criteria, it's about risk review. So the CPPE risk management, e-assessment and e-learning needs to be completed by pharmacy professionals. A new risk review needs to be included in that to minimize the risk of transmission through COVID-19. All pharmacy professionals need to understand and recognize the risk associated with their professional practice, and hence it's really important that you update your previous risk reviews as part of your last PQS. And of course, if you haven't already done so, pharmacy professionals need to have completed the CPPE, sepsis, e-learning, and e-assessment. If you haven't done the risk reviews as part of your previous PQS, then you'd need to complete 2 additional risk reviews. Again, we can help and support with that, and I'll explain at the end the support we have and we're able to provide to you. Moving into the quality domains. So now you've got the lock that opens the door. The gateway criteria are essential, because if you haven't got the keys that will open the door, then there's no point even touching the quality domains. So the hope that you've addressed these issues, and now you're moving on to the quality domains. Of course, the anticoagulant audit is a very quick win, and I'd suggest, and the advice I've given my pharmacies is that we're doing this in November. We've got a busy December period coming up. And January is when we'll be doing the claiming. So the best time for us is to actually get this done in November. Of course, the purpose of the audit is to address the key recommendations as set out by the previous audit that was done in 2017, and the recommendations that were set out by SPS, which was around the referral process for patients that were co-prescribed, medicines that were increasing the risk of bleeding, the provision of oral anticoagulant alert cards, and of course, supporting patient knowledge about the potential interactions with their medicines. The audit needs to be submitted separately on MYS. So there is a section for pharmacy quality scheme, but you'll also see the anticoagulant audit section, and it's important that it's submitted via the anticoagulant audit section on MYS. The next part of the quality domain is around the respiratory domain. This is separated into 3 sections. Let's go into the asthma referrals. All children aged 5 to 15 that have been dispensed inhaled PMDIs for asthma must have a spacer device where appropriate and in line with NICE. Of course, that doesn't mean you provide them with one. It means that they must have it. Now, some patients may wish to buy it, which is fine. That's your own prerogative. All patients 5 years and above with asthma must have a personalized asthma action plan. Now, historically, when we've done this service before with asthma referrals, a great success for us has been informing the GPs beforehand, informing the practice beforehand. They can be fully supportive, and I'll go into the next part, the respiratory domain, where they can be very helpful to us when it comes to NMS. And in fact, they would prefer it if we took charge of inhaler technique checks, etc. And generally, they're not then stumped by the fact that they've received a referral form through our farm outcomes and not know what to do with it. So you can still claim payment as previous respiratory domains if no referral has been made, as long as you have a process in place. Now, the PSNC template in terms of the referral process is actually fantastic, and I would really recommend that. And we've incorporated that into our workbook. So going into part B, which is the technique checks. Pharmacists must complete the inhaler technique e-learning and e-assessment. Now, there was one before April 2020. If that's the one you've done, then it doesn't count. You do need to do the one that's after that. Now, the inhaler technique checks to asthma and COPD patients, you would also have to offer catch-up NMS on those patients that you would have lost between the 1st of April 2020 and the 31st of August 2021 that you couldn't offer to during the pandemic. Now, this can also be done virtually. Again, GPs can really help and support our NMS process with that. So it's important that we have conversations with our general practices around what we're doing around the respiratory domain and getting this support with this. The third part of it is returning of unwanted and used inhalers. The pharmacy must be able to evidence that they have spoken to through either verbal communication or other with patients or carers or their representatives who have been dispensed an inhaler between the 1st of September and 31st of January about the environmental benefits of them returning all unwanted and used inhaler devices to community pharmacy. PSNC has produced some great material with that, and we've basically put it into little A5 sheets, which are easy to put into pharmacy bags, etc., to make it easier and also engage in conversation really easily. So I would recommend that you make use of the information that's available to you there. And of course, it's important about training and educating your teams on these conversations. The next part is the digital domain. This is a very easy one. CPPE, remote consultation skills and e-learning needs to be completed by all pharmacy professionals. And it goes without saying that this is going to be something that's going to be the future of pharmacy. So ensure that you've got your trainee pharmacists, trainee technicians also on board because they're going to have to do it at some stage anyway, and update your SOPs accordingly. You can download a certificate of study, because there isn't an assessment. So therefore, you can download a certificate of study as evidence for this. Primary care networks. So the PCNDs will get around 10 points more for their role in this. And let's go into what the PCN lead needs to do around, and primary care networks is really focused around flu this year for obvious reasons, especially with the pandemic as well. They must be able to collaborate with all the contractors that have wished to be participated in the flu campaign this year, and GPs and other stakeholders. They must agree a collaborative approach with the PCN director. So likewise, non-PCN pharmacists, non-PCN pharmacies must communicate with their PCN lead and be part of that uptake in in the flu provision. Every pharmacy is required to also administer 30 or more flu vaccinations by that key date of the 31st of January 2022. Just having a look at some of the data that's coming through, it is worrying that many pharmacies still haven't engaged yet. And of course, points are earned if the PCN practice if the PCN practices reach over 80%, and I think it goes up to about 86%. So, moving over to the prevention domain, we must complete the antibiotic review using the target antibiotic checklist. There are a minimum of 25 patients over a 4-week period, although that can be extended to 8 weeks. The submission of the data must be via the PHE portal. So if you did meet the AMS domain last year, you would review and update the existing action plan. We've got template action plans available, and we can also support you with the updates and what you'd want to put into a review. If you haven't, then you would need to obviously complete the training and the AMS training, and you would also need to do an action plan with a view to updating it. The next bit is around addressing unwarranted variation in care. Pharmacy professionals must complete the CPPE Health Inequalities e-learning and e-assessment. Of course, that's important because the purpose here is to complete an action plan into promoting the low levels of vaccine uptake in BAME communities, incorporating myth-busting methods. Now, of course, what does that mean? So let's go a bit more into detail around the kind of stuff that needs to go into your action plan. We know that obviously the BAME population is most adversely affected, and there is most hesitancy in that population also. So your action plan needs to be around how you can tackle these issues. Of course, that would incorporate signposting to local vaccination sites. If you're a local vaccination site yourself, and more pharmacies are being encouraged to actively take part in the COVID vaccination program, then putting your details onto the Grab a Jab website, etc., making yourself more available, more accessible. We've done stuff like having a separate phone line as well, having people of different language capabilities, etc., to help and support. We've done a bit of outreach work in mosques, and we've got some of our vaccination sites also set up at gurudwaras, etc. But obviously, if you haven't got that, then at least you can signpost to local sites that are providing that to BAME population. And of course, whilst people are having the flu vaccination with you, it's a fantastic opportunity to be able to promote the COVID vaccination program, especially right now as cases are on the rise in many parts of the country. And of course, your myth-busting methods must also incorporate conversations that people might be having around, for example, the fetal cell lines or animal products or the myths about the chimpanzees, etc. All of that information is available actually through the NPA webinar, which I'm happy to link in after this, which was absolutely fantastic at myth busting. So if you haven't seen that NPA webinar on tackling health inequalities, I think it's really, really important that you jump onto that, and that will actually help and support you develop an action plan exactly on this area. I hope that helps. Moving into the healthy living support domain. So all non-registered staff need to complete adult obesity and childhood obesity training, and all registered staff need to complete the CPPE weight management, e-learning and e-assessment. You must then be able to create and update a weight management action plan. Again, we have a workbook that can help and support you guys with that, and proactively discuss weight management with at least 25 individuals. You must then be able to measure BMI. The PSNC and the DHSC then stated that you need to refer at least one patient to the digital weight management program. But of course, if you haven't got the information beforehand, you're going to find that a bit difficult. So let me just guide you through what you need to do. When it talks about referring someone to the digital weight management program, they must have either diabetes or hypertension or both to be eligible for this program in the first place. When you're referring, it's best to have the patient sitting in with you. The reason is you need to ask them a few questions about their health. You'd also need to measure their BMI. You'd also need to basically ask or get their NHS number. So you need to seek consent to access the NHS fine, get their NHS number, and that is actually an essential part entering their data into the referral system. You would also need to put in the GP practice ODS code, which you can also get through the spine. This is different to the asthma referral domain, because in the asthma referral domain, you could basically have a process in place and still claim. Here, to claim the additional points, you'll get, I think it's equivalent to 4 or 5 points, the additional points for a referral, you would have to do a referral. So it's important that basically you're able to get all of this information beforehand. You must also, goes without saying, seek consent from the patient to have their information shared with the pharmacy and the GP. What then happens is that the patient gets a text message or an email to register. The patient then registered, and then they have access to 3 systems they can choose from. They can choose to join what we call Second Nature, which is a program that they can lose weight by without counting calories, using behavioral science. Liva, which is a personal health coach with tailor-made guidance, or Xyla, which is a personalized physical activity program, and sort of gives a bespoke lifestyle plan. Now, the thing is, this information isn't available on the PSNC website. So in order to know what you're referring the patient to, because no doubt the patient will have questions, I think it's important that you just jump onto the NHS Digital Weight Management Program and just look at the information that's there, which will kind of be a bit more detailed around this. So then you can give more informed guidance to those that you are referring. Just looking at one referral recently, I think it's really valuable. I think it's something that community pharmacies should really take on board. And I think if we use it in the right way, I think it will have a huge amount of benefit to the local community. So what we're doing here is we're setting you up on an initial webinar, and I'm conscious it's been quite quick. I wanted to do it quicker than the PSNC webinar, because you would have already, a lot of you would have already listened to that. But essentially, there's a bit more detail that we've given around some of the things that you can do. But we also want to just have regular check-ins for those that want to participate on a regular basis, just ask a few questions. But we also want to do something differently around supporting everyone, whether you're a Lexon customer or not a Lexon customer. We just want to ensure that we maximize this, because it's really important for us from a community pharmacy contract perspective that, you know, it's been a very difficult time with the pandemic. So I think as community pharmacy contractors, we need to show the Department of Health that we're doing all that we can to maximize the opportunity that's presented to us here. So we've got email support as well, which is my email address here and my direct contact telephone number, if you wish to seek advice on any questions that you may have. We've also got a workbook. There is a nominal cost to the workbook around distribution and printing, which you can access by Lexon events. So we're not charging an extortionate amount. It's just basically around the nominal cost around distribution and printing of that workbook, including the little bits of documents that are in there that you can share with your pharmacy teams. For example, the NMS guides, etc., that you put up on your walls. It's quite detailed. I know PSNC are coming up with their own workbook, but we had to kind of get cracking with this beforehand because we didn't want to wait until November for a workbook, especially when we've got to start an audit. So this workbook is ready, it's ready made, and it's there available for you guys should you need it. This webinar will be available free of charge. Second, everything is really available free of charge in terms of check-in sessions, etc. The whole point here is to ensure that we've got a supportive network around community pharmacy contractors, and we'll continue to do that throughout the way. So I'm going to open up the floor for questions. There is an action plan that I'll send over to everyone that's attended so that you can start to tick off that action plan. And we'll also share the recording from this. You can share that with your colleagues in your pharmacies as well. And I'm happy to share the PowerPoint presentation as well. So the support is out there. Please use it. And I guess I'll open up for question and answers. Myself and Pete will take whatever questions that you've got.
Okay, so first we're just going to run through some of the questions that have come through as Mo's been presenting there, and one of the questions was in regards to aspiration payments And if we don't claim the aspiration payments, does that affect our total PQS payments? It doesn't. Aspiration payments are there as an opportunity to improve your cash flow. If you're confident that you're going to be claiming all PQS points, then it's a useful way to get some of that reimbursement early on. It will, if for any reason you don't manage to complete the PQS payments, then that would be deducted when the total calculation is done. Question here on the anticoagulation audit. Are we expected to just complete the data collection section or complete the full audit? It is primarily a data collection exercise, and we do hope that NHS England will share some full audit data from that. But there is page 10 of the audit documentation, which is used for recording some specific actions. I've answered with a link on the PSNC document and also a link to the NHS England document, which is in the question answer section. A copy of the slides, absolutely. We can share these with everybody who's registered, along with the video recording. And Mo has talked through how to access the workbook with the email link there to request that. Okay, so let's just see if there's any new questions coming through. So, Mo, can you confirm? Do we know what the cost of the nominal cost of the workbook is?
Yeah, so the nominal cost, I believe, is £29, and that just covers its. Let me see if I can find it. I don't know whether you guys can see me. So it just comes in a workbook which has a lot of laminates, etc. in it. This is a kind of it's about that size. It's got in it all the information that you need for your pharmacy staff, literally just to work through. But again, it's just a distribution cost, and it's around £29 for that. The one thing I would say is whether you have the workbook or not, the support is there, in the sense that we're going to do another training session towards the end of November. We're not going to regurgitate the same stuff. What we're going to do is we're just going to set up a question and answer session and just address any concerns that anyone has, anything that they're worried about, etc. And we'll do one just before the claiming period in January as well. We just want to ensure that everyone's got things tied up. So that will all be available.
So I've got a question for you, Mo. If you haven't started the PQS work already, what is the first thing that you would do?
The first thing that I would do is I would focus my team's energies on the NMS and the anticoagulant audit. I think those are the two big things. So from my perspective, it's around maximum, because we want to future-proof our pharmacies. It's not just around hitting the 20 NMS. It's around maximizing the opportunities that are presented to ourselves around NMS and the catch-up NMS. So I think it's NMS and the anticoagulant audit. That would be the two big things for me.
I found it really interesting the other week because I was looking at some of the data on NMS completed by the pharmacy industry. And in June this year, would you believe there was 28% of pharmacies did not engage with the NMS process at all? No claims at all in 28% of pharmacies.
And I'm keen to understand what the barriers are, because, you know, honestly speaking, it's such a missed opportunity, and they're kind of just telling us, hey, look, we're gonna allow you to do it over the phone. We're going to allow you to get verbal consent. We're even going to tell you that those ones that you missed in the past, you can do them. So I'm just thinking to myself, hang on a second. You know, they're kind of saying, you know, we're going to lift all the barriers. And then it just perhaps boils down to, I mean, I always tell my pharmacy teams, there's only 3 reasons why you can't do something: skills, capability, or behavior. Skills, where we're capable, then it goes down to, have we taught them correctly? Or actually, have they not got the right behaviors? So look, the skills are here, but the skills can also be taught. You know, pharmacists are leaders. but then it goes down to behavior. So my big ask is, what are the barriers? What's stopping, nearly a third of our pharmacies not doing NMS and potentially missing out on such an important criteria, gateway criteria? That would be a real bummer if you didn't pass that gateway criteria and weren't able to get any part of the PQS.
Yeah, and I think we've got to be honest. I think as Sanjay here says, it is time to be honest with NMS. It's what the NHS want us to do, and they are incentivizing and putting numerous things in place to make sure that we do that. So other thing there that we haven't chatted about tonight is transitional payments. So have you all realised that the transitional payments that are extending into this year, half of that transitional payment will only be paid if you complete NMS in the previous month. So for 28% of pharmacies, the difference between completing one NMS and zero NMS could be in the region of £1,000 per contractor. So I think we've all really got to really get on board, get our teams behind the NMS, because they're certainly not going away. So we've got a couple more questions coming through here. So,
the question was the 28% in June because we were so busy due to the circumstances at that time. Yeah, it could well be the case, but bottom line is this is bread and butter now, isn't it? That's the way I see it. And the other thing is prescribing output has really remained. I mean, footfall, certainly retail has been impacted, but prescribing output hasn't significantly dropped unless there was certain areas, for example, health centre pharmacies. We did notice that prescribing output significantly dropped in health centre pharmacies. With the verbal consent, what records would we need to keep? A PMR, put down that basically patient consented verbally on the PMR record. There is a flu vaccine scheme and we must participate in the scheme, but flu vaccine is not available. Where can we get it, and where can you and if we cannot, we can't apply for PQS? That's a good point, Pete. Don't know whether you want to address the lack of availability of the
so I think picking up from what Mo had described in the presentation. So two things. One is engagement with the PCN. And that is being in a position to willingly participate in conversations and direction of patients towards getting their flu vaccine, which should hopefully overall increase the percentage uptake within the area. So if you don't have vaccinations in stock right now, it's about making sure that we've forwarded patients onto an appropriate source locally. If you haven't got any vaccinations and haven't had any vaccinations so far, then you will find it difficult to meet the requirements of 30 to meet that domain. However, there is some stock planned to be available, which is categorised as Department of Health and Social Care stock. From what we are aware, that isn't going to be available until mid to late November, but that can be ordered from wholesalers, and also the CCGs may have contact details of how that can be obtained locally. So you may not have vaccine stock right now, but maybe hold tight, contact your suppliers, and hopefully at least 30 vaccinations are achievable by the time we get into November.
Just a quick question about NMS being difficult to organise. They don't do many. Could you outline how you organise the follow-ups? Well, a quick win with your follow-ups is the fact that your catch-up NMS, your intervention follow-ups can be done together. Some PMRs actually allow you to go back on the record and see how many you'd missed, and you might find that you'll find quite a few NMSs that you'd missed. Obviously, different companies have different control sheets, etc., whereby they monitor that. But we actually make use of the PMR to organize our intervention and follow-ups. And I think a lot of PMR providers are very good at that. Could you repeat the mantra regarding the ability to achieve a result? skills, behavior, and capability. I'm claiming IP on this. I believe that there are only 3 reasons why human beings can't do anything. One is skills, the other is behavior, and the third thing is capability. It could be one of 2, it could be 2 of 2, it could be 3 of, it could be 3 of, sorry, 1 of 3, 2 of 3, or 3 of 3, like a Venn diagram. I think those are the only 3 reasons why things don't get achieved: skills, capability, or behavior. So the question would be, which one of those 3, or what 2 of those 3, or what 3 of those 3 might be stopping us from achieving what we want to achieve?
So a question here around, is it 30 over 65-year-old vaccines or any age? My understanding is it is any age.
Yeah, it's any age. Yeah. As long as they fit the NHS criteria. Yeah. So how do you do weight management if you do not see a patient that ticks the requirements and consents to the requirements? So unfortunately, you will miss out on the referral part of the weight management category. So the weight management category has a referral element to it. So you'll miss out on that bit if you do not refer a patient, but you will get the rest of the weight management category. Are we still okay to submit NMS in a good old-fashioned way? What do you mean by that? This is all great support by Lexon. Just wondering what's in it for Lexon. I'll let you answer that one, Pete.
I think being absolutely honest, it's in everybody's interest that the independent sector thrives, and that means that we can continue to drive forward and have successful colleagues across all areas, and that is obviously what Lexon wants to do, is to continue to be a supplier to independent pharmacy. Yeah,
I mean, we find that the corporates, larger corporates like Boots, where I come from, and Lloyd's, they have this quite well wrapped up within their organizations, but from an independent contractor perspective, there's a lack of support out there, and what we want to do is we want to try and fill that gap where we can. Obviously, LPCs are doing a fantastic job, and we want to be able to help and work with them, as well as our independent contractors, to give the best offering possible. So this is something new that we're doing, and we're hoping that we can continue to do lots of this, including leadership programs, provide it free of charge as part of what we call the Lexon Healthcare Academy, hopefully.
Okay, so I've got an NMS question here. So for catch-up NMS, does it mean that patients started new meds 6 months ago and we can call them to do NMS? Will not patient be thinking that why we are asking all info now? Just wondering. So if you look onto the NHS BSA website, there is a new service specification for the NMS service, which has been amended. And there's a couple of paragraphs that deal specifically with the catch-up service. And the eligibility period is throughout the pandemic up until August this year. So any patient who did start a medicine and was eligible for the NMS will fall within that. In our analysis, that could be in the region of 400 to 500 patients per pharmacy, for an average pharmacy. And the nature of the service is it describes a fairly pragmatic approach, in that when you're contacting the patient, they've obviously already been taking the medication and may well have already come across any issues or not, in which case the intervention and follow-up can be done as part of the same call. It could, however, be that some information or advice is provided and a subsequent follow-up is required. But I think the way that we've approached this is to explain to the patient that the NHS are really keen and invested in patients getting the correct use of all new medicines, and it's a follow-up call. Obviously, the NHS has been under significant pressure over the years. I think it's very much just about communicating that correct message to the patient, that we're here to help and offer a service to them.
Question here, person said a bit of a silly question, but how and where, when is NMS claimed? It's not a silly question at all. It's often a question that we get asked. So if a patient is uncontactable at the first intervention, you can't claim payment. If the patient at the first intervention doesn't take the medication, you can't claim payment. If the first intervention is complete and the patient has been taking the medication, then it's fine. If the second intervention is incomplete or the patient is lost to follow-up, you can still claim payment. So what I mean by that is the follow-up. If the follow-up doesn't happen, but the intervention is complete, the first one, then it's all good.
Question here on, is the CPPQ, so that's the Community Pharmacy Patient Questionnaire, back on for this year, as has questionnaire in post? So one of the announcements that did appear on the PSNC website was that contractors are expected to fulfill all contractual obligations this year, which unfortunately that does mean that CPPQ is included in that. Now, we've been working with our friends at Farm Data, and very shortly they will be releasing a online tool which will allow you to use a online link to gather all of the CPPQ questions electronically. That will also have an ability to analyze the data and present that in a suitable report. So if you haven't got a plan in place for completing your CPPQ, think that a paper-based approach is going to have an issue for your patients and your staff, then do keep in touch with the farm data guys, and well, I think our reps will also be able to share information on that offering very, very shortly.
I don't know whether we've addressed this one. If you have been doing NMSs throughout the pandemic, can you include those? Obviously you would probably have claimed for them already if you had already claimed, so you can't claim for them again. But I don't know whether I've understood this question properly. But if you haven't claimed for them, they could potentially be claimed as catch-up NMS, is my understanding. And also started flu vaccines in September. Can these be your 30 vaccines? Yeah, so from the day, obviously, the PGD landed. Yep, no problem. Any other questions at all?
Oh, there's a question here more. Do we need any special equipment for weight management to measure BMI?
I don't think the guidance states any special equipment, but if you look at the previous PQS we had, it did go through the risk assessments needed for your measuring scales and so on. So as long as they're well calibrated, then that shouldn't be an issue. Can I ask what your typical approach is to carrying out NMS? I tend to talk to my patient at the start and then follow up often feels pointless. Okay, so here, can I ask what your typical approach to carrying out an NMS? I guess we've started to implement a few different procedures. The biggest thing for us is ensuring that we're making use of the PMR and we enable the pharmacy team to lead with this, in the sense that what we've tried to do is empower our captains of the ship, especially our pharmacy technicians, to present our pharmacists with the daily NMS record sheet. So our pharmacists know what phone calls they have to make that day, etc. And I think that's a really important part of in training and empowering your team. So I think use the qualities of the team that are around you to ensure that basically they're leading with this and they've got ownership over this, not just your pharmacist. And then it says follow-up often feels pointless because obviously, yes, you've had those discussions around side effects, etc. at the start. But honestly, you come across so many times where patients develop issues or side effects, or they've been told by their GP to stop it, and you suddenly, you went and passed that information. and they're a Dorset box patient or whatever. So there are so many things that you'll find, and it's, you know, 1 in 10 or whatever it is, and that could be a life-changing opportunity. How can we get a copy of the slides and the link to the webinar? So all of your emails have been taken down in this wonderful world of IT. So don't worry, we've got all of your information, and we're going to pass it back to you.
Okay, so there's a question there that's asked us to repeat the part with regards to NMS and how it affects transitional payments. So I'll cover this this bit kind of from the beginning, and hopefully that helps to clarify everything for you. So for the first 2 years of this year of the 5-year funding deal, transitional payments were included, and the reason for that, as it was anticipated that it would take a couple of years for enough services to be set up and established that would then use the cash that had been freed up from the removal of the MUR and establishment payments. However, due to the pandemic, the number of new services that set up and the development of the GPCBCS and the CPCS schemes haven't taken off as well as they could have done, which has left effectively a pot of money that needs rightly to be distributed to contractors. So part of this year's negotiation from PSNC was that the transitional payments would continue for a 3rd year. Okay, now that previous 2 years transitional payment was purely calculated upon your items banding of the pharmacy, but from September, I think it is, yeah. So from September, the transitional payment, and this is introduced in page 59 of the tariff. It explains that the transitional payment is split into 2 halves. One half based upon the your NHS items banding, and the other half based upon a service element. The service element specifies that to get that element of funding, you must complete 2 things. One is be participating in the CPCS scheme for at least half of the days of the month. And the other aspect is to have completed a minimum of 1 NMS in the previous month. So that's where we get to the aspect of completing 1 NMS can ensure, or worse, at risk of you losing your transitional payment for that month.
It's gone under the radar, hasn't it, Pete?
I think for many people it may well have done, yeah, because I guess from one aspect, if you were a pharmacy that did no NMS, that one could be worth £1,000 for you. But if you are a pharmacy that's regularly engaged in the service and for whatever reason a member of staff is off on holiday, somebody forgets to claim, that could effectively cost you £1,000 worth of income. It is banded, so it's not a straight £1,000 for everybody, but a typical average size pharmacy, the transitional service element could be about £1,000 per month.
There are some overlap modules from the last PQS. Do you have to redo any of them? No, so especially with the e-learning, you do not need to redo it. And a lot of the audits, a lot of the reviews are updates if you've already previously done them, except for the COVID-19 risk review, which actually does have to be done again. You can use the same certificate. Do we have to, yeah, I think I've answered that one. So if in previous years we completed and conducted risk assessment, LASA, sepsis, etc., do we have to complete the training again? You don't have to complete the training again. You do have to update the risk assessment. The COVID-19 risk assessment does need to be done again. That can't be updated.
I think if my memory serves me correctly, Mo, there are 12 training aspects in this year's PQS, 8 of which have featured previously. So for many members of staff who are established in the pharmacy, it may well just be a quick check to make sure we've done it. But if you've got new members of the team over the last couple of years, they may have more to do than others.
Yeah. So I think there was a question around NMS 5th of January 2022 is the deadline to achieve your 20 NMS by. And the date parameters for your the catch-up NMS is I think it's the 1st of April.
It's September to March is the 6 months that catch-up NMSs have been.
September to March.
Yeah. I think the other thing as well that we may not have mentioned is, did everybody know that the NMS maximum cap has been doubled? So that's gone to 1% of prescription volume. To just put that into easy terms, if your pharmacy completes 10,000 items per month, then your NMS cap, so the figure that you won't be paid any additional NMS, will be 100 from now on. Previously, that cap would have been sat at 50, which was previously 0.5% of items.
What are the date parameters that we have to perform NMS before we can claim gateway? 5th of Jan.
I think the thing to think about there is the gateway is reviewed at the end of the scheme. So it's not that you need to work to fulfill your gateway now. You've got to make sure you've achieved the gateway at the end of the declaration period.
Yeah. Any more questions? I think we've done well. 1 hour.
Yeah, really pleased with the amount of questions we've received there. Nice to have an engaged audience joining us.
Yeah. So we'll be sending out in the next few weeks to those that have participated today a further link for the next session, which will be a catch-up session for PQS for anyone that's struggling to join. We'll also be in the next few days sharing the slides as well as the recording. You can share that with your teams. And we will also be sending guidance around the workbook if you wish to get that. So thank you very much for joining us, guys. I think, is there one more question coming through? Oh, right, okay, it's just a thank you. Brilliant. So Pete, did you want to add any final bits or?
No, nothing else from me. Thanks everybody for your time and your participation. Hope it's been some help. But yeah, the door's open if anybody requires any support or assistance. I think very much we're all in this together. We want pharmacy to succeed. An absolutely independent sector is critical in that.
Thanks all. Have a great evening. Bye.